is a good friend of mine. I'll start with that. I actually met Marcus a long time ago. I think it was about 5 years ago at Eshrey. And since then, I've been bumping into him at all these conferences, Eshrey, Aspire, etc., where he speaks regularly. I think I vividly remember, I think it was Eshrey 2015, where there was a Vitrolife symposium and Marcus was speaking at it. And that's where we had a good chat about time lapse. And I think it was his experience and it was the kind of knowledge that he possessed at that moment, which actually influenced me in getting a time lapse for my laboratory as well. And we've never looked back after that. And I think I've really enjoyed using time lapse, and that's one of the reasons why I put it as a topic for today. So Marcus started his journey in the field of embryology way back in 1992, where he started working for his PhD in developmental biology at the German Cancer Research Center in Heidelberg. He then worked at the National University Hospital, Singapore, where obviously Professor Nag was working with Susie at that moment. He then became the lab director in a private IVF unit in 1993, then the director in the IVF laboratory at University Clinics in Bonn in 1995, professor of experimental reproductive medicine. That title sounds really cool. So he became a professor of experimental reproductive medicine in 2009, and in 2011 he again joined University Clinics of Heidelberg as the head of IVF laboratories. And since 2013, he's exclusively serving as the CEO of his consultancy company, iLabcom, in Germany. So Marcus has a lot of experience in time lapse, and we're really looking forward to your session today, Marcus.
So thank you very much. Thank you very much, Keshav, for the introduction. And it's always nice to be back in India, even if it's only virtual nowadays. But I hope times and days will come where we will meet again face to face. Now, Keshav asked me to give a talk about time-lapse in clinical practice. And before we go later on to hopefully a very vivid question and answer session, I'd like to give you a very, very short overview. First of all, I have conflict of interest because I'm doing consultancy for companies, and one of the companies I'm doing consultancy for is Vitrolife, where I'm also somehow involved a little bit in development of time-lapse devices or time-lapse software. When we go back in the times of time-lapse, this started a decade ago, I would say. In the beginning, everybody was intrigued, first of all, by undisturbed culture, and second of all, by having the possibility to look on the embryos all the time. Now, this slide here shows you a little bit an overview about the improvements which we get by undisturbed culture. So all these papers here did not use any algorithms. They only used time-lapse as an incubation device. And what you can see is that at least if we look on the blastocyst rate, we get an improvement of time-lapse compared to conventional incubation. No matter in which country you are, no matter what outcome you look at, it's the blastocyst rate, it's the usability rate, or even blastocyst morphology. Then, if we look on the clinical outcome, comparing time-lapse with a conventional incubator, again, without using any algorithms or any software in order to select embryos, simply using normal standard morphology, then we can see actually that the time-lapse devices, as you can see on the graph here on the right side, perform much better in terms of pregnancy rate and ongoing pregnancy rate compared to conventional incubation. The interesting thing is that here there is a comparison which was published at Eshrey this year, where they compared actually time-lapse and a humidified incubator, time-lapse dry versus time-lapse humidified, and you can see actually that there is no big differences in terms of pregnancy rate and implantation rates, which I think is very important because humidification is one of the issues which is very hot discussed in the field of time-lapse. When we actually look on the clinical outcome in minimal stimulation programs, now minimal stimulation programs are programs where you definitely have not much to choose from. That means you usually have 1 or 2 embryos which you can culture. And what we see here is data from Cardoletis Clinic. And I think it's quite interesting to to understand that Cardoladis Clinic has pretty good data by using time-lapse versus their traditional benchtop incubators, and that without being even able to select embryos. That I think is quite interesting, because that's really showing what is the real benefit of an undisturbed culture. When you cannot select embryos later on, you're really only looking on the incubation system itself. No, where are we? So after using undisturbed culture, I think the next point in time-lapse is, of course, morphokinetics. And morphokinetics, first of all, goes down to those things which are completely new. You all know that as soon as we started using time-lapse, we could see certain things which we never saw before, like direct cleavage 1 to 3, as you can see here, or direct cleavage 2 to 5. This was something we were not aware of, and all of a sudden we realized that this is sometimes quite a big problem, because it can go up to 20–25% of all the embryos showing that, depending on your conditions in the laboratory as well. Another thing which I think came more to the attention of embryologists was multinucleation. And I really like this paper here, which was an abstract at ESHRE last couple of months, where they actually looked on embryos that showed multinucleation. And they followed these embryos with time-lapse, and they could see some embryos, they actually excluded the blastomeres with multinucleations, versus others did not. Now, if you look on the orange bar here on the very right side, that's the clinical pregnancy rate and the live birth rate of multinucleated embryos that have excluded the multinucleated blastomeres. That means they did a kind of self-correction. I think, first of all, this shows that multinucleation is really something we should be concerned about. But I think it also shows that time-lapse is a perfect system in order to help you to follow these embryos and maybe even use them and rescue them for later use when you see that they have this exclusion of blastomeres undergone. Now, what about the clinical application or the clinical use? You may know that Csaba Brzezinski, who initially invented the Primo Vision system, and me, we did a meta-analysis of RCTs where all these RCTs used algorithms. That means they looked not only on undisturbed culture, but they also looked on more morphokinetic variables, and they combined these variables with time-lapse culture in order to select the embryos. And when we look on this, we can actually see that the ongoing pregnancy rate in time-lapse in these 5 RCTs compared to standard incubation is going up. The live birth rate is going up, and the early pregnancy loss is going down. And the green bars shows you the improvement which we get compared to standard incubation, the relative improvement. And that's quite, I would say, astonishing that we have such a big impact, which we can see when we use time-lapse with the algorithms. Now, there are several algorithms out there in the field, and I just simply would like to draw your attention to this algorithm here, which is called KidScore Day 3. KidScore Day 3 is an algorithm which was developed by Vitrolife. It looks for day 3 embryos, and there is a nice study which was published by Adolfson in 2018. She first looked on what is the clinical outcome of blastocysts on day 5–6 if they were stratified by the blastocyst score. How does this correlate with the clinical pregnancy rate and the live birth rate? And you see, of course, like top quality embryos have a very pretty good outcome in terms of live birth rate and clinical pregnancy rate. Now, she used also in this paper KidScore Day 3. So when she had a good or top quality blastocyst, she applied KidScore Day 3 in order to differentiate by the KidScore on day 3 the blastocysts on day 5. Top quality blastocyst, and either you have a low or a medium or a high KidScore, and depending on that, you get actually a difference in your implantation rate and in your clinical pregnancy rate. And I think the smart thing about this is it shows that top and good quality embryos are not always good for implantation. And we know that because we don't get 100% pregnancy rate naturally. But you can see that some of these top and good quality embryos have a very high live birth rate, like 44%, and others have a very low one, like 17%. So by adding morphokinetics, even from day 3 to day 5 morphology, we actually have a benefit by getting a better implantation rate when we can subselect among blastocysts. Naturally, it makes sense to also develop a day 5 algorithm, and this has been done. It's named KidScore Day 5. Now, meanwhile, there is a third version of this. That means this algorithm has been developed further and further and further. It works in reduced oxygen with IVF or ICSI and with different culture media. And it looks on variables up to T5, then on TB and the ICM and the trophectoderm. And what you can see here is for the different scores, how the implantation rate actually goes up. And this means that the better the score, the higher the implantation rate. It's interesting again to go back to Cartolatis Clinic, where we perform low stimulation cycles, and they sometimes have 2 embryos in some of these low stimulation cycles, which they culture to day 5, where they then do a selection. And these data here are quite interesting, because if you look on the previous curve, which was this one in relation to implantation rate, and you compare this with the curve which is obtained in Cartolatis Clinic with low stimulation cycles, and all the embryos had been actually frozen and then transferred in a frozen embryo transfer cycle, you can see that this curve looks almost the same. So KidScore Day 5 really pretty well correlates with the implantation rate of fresh blastocysts, but also of frozen blastocysts, and not only in high stimulation programs, but also in low stimulation programs. Let's go on, because many people started to argue about, what is the value of time-lapse when we have, for example, PGT for aneuploidy screening. And I show you here 2 graphs, which again, I think are quite illustrative, because they show the synergy between time-lapse and PGTA, and especially between a day 5 algorithm and PGTA. On the left side is a study from a clinic in Thailand, again, very new data from 2020, ESHRE. What they show is that euploid embryos after next generation sequencing and day 5 biopsy have a much higher mean KID score than, for example, embryos with complex abnormalities or chaotic embryos. They actually have quite a low KID score. This does not mean that you can differentiate only by the score between euploid and aneuploid embryos, but it already gives you a kind of guidance, I would say. Interesting is this graph here on the right side, because this was a study performed in Taiwan. And what they actually did is they did next generation sequencing when they had euploid embryos on day 5, day 6, and they selected the embryos for transfer based on the KID score. And what you can see is that euploid embryos with a low or high KID score show a very clear differentiation in the implantation rate. Implantation rate actually can go up to 75% if you have a euploid embryo which has a very high KID score. And that shows to me that once you are working in a PGT program, where you at least have 2 blastocysts which are euploid to choose from, it definitely makes sense to use an algorithm in order to select the embryo for the transfer in the fresh cycle or in the frozen cycle. Now let me summarize this until here before we move on, because what we can see is we have prediction algorithms in clinical embryology, and believe it or not, but also the Gardner score is, for example, an algorithm because it gives very clear values, and if you have these values, then it tells you you get better or less good results. So that is the manual assessment which we did for a long time by basic morphology on day 5, and that I would say is a manual assessment Gardner score algorithm. But IVF is an evolutionary process, and with the introduction of time-lapse, we started to use morphokinetic parameters for the manual assessment. And this was also something like an algorithm if you exclude, for example, direct cleavage or reverse cleavage. But we also then can actually add further things like guided assessment. We all know that manual assessment has certain problems, and that is the subjectivity. By using guided assessment, especially for those morphokinetics which you are going to choose later on for your algorithm, you can actually improve your workflow. This is maybe a little bit a complex graph, but I like to show you what you can do. So you have a bunch of pictures from an embryo, and it's either the embryologist which can actually make the annotation, or it's a kind of indirect AI, which can make the evaluation, propose the values to the embryologists, and the embryologists can approve. And that is what we call guided annotation. Or you have the direct AI. First, I'd like to talk about that one, and then I come to the direct AI. So when we look on KidsScore Day 5, during the development of that, many embryologists were asked to score blastocysts in order to get a kind of gold standard for blastocyst scoring. I was one of them, David Gardner was one of them, and some other people were involved. And I can tell you that very often we didn't agree on the scoring of a blastocyst on day 5, which I think is natural because each of us has a slightly different view, but it also shows the subjectivity. Now, what has been done in Vitrolife is that they have developed a so-called indirect AI tool, which tried to make a kind of morphological prediction of the score of the blastocysts. And the gold standard or the comparative standard were actually human embryologists. So it was a data set of 55 blastocysts, and they had 5 embryologists or more involved per blastocyst. And this here is a kind of majority vote. That means for the ICM and the trophectoderm, the embryologists agreed in 65% of blastocysts for the same ICM grading, and in 74% of the trophectoderms for the same trophectoderm grading. Now, if you look on the AI, it's quite interesting because the AI is not an embryologist. It's actually an artificial intelligence system which tries to learn from the data which are fed in, and in order to predict what the blastocyst score looks like. And on the same data set, the AI after training performs equally good or better than the embryologist. And I think that's quite interesting. And I think that's something you should already now start to remember. An AI is always of benefit when it's at least equally good as an embryologist, because the AI will do it automatically. It will do it objective way. And it will not have any discussions in the laboratory with other embryologists because the AI is quite strict. It doesn't discuss things. So this has been implemented in a software called guided annotation. And for example, if you use KidsScore Day 5, you can see here the KidsScore Day 5 values, and guided annotation immediately proposes you certain values. For example, the number of 2PN, the grade of AI, of ICM and trophectoderm, but also the morphokinetic timings, 42, T3, T4, T5, and TP. You can see that some of these here are bold. That is where the guided annotation is very sure that this is the correct value. And some of them are not bold, they are actually pale. This is the 2 values where the guided annotation tool tells you, oh, I'm not so sure, better check it. And I think that's quite interesting because it means if you have this here, which will immediately pop up once you open the image of the embryo, you will immediately have these values and you only actually need to check for T4 and TP. That makes your annotation very fast and makes your workflow very fast. And by the end, actually, you get a more accurate annotation and more accurate KidsScore values. Now, guided annotation is a kind of intermediate step. Why? Because it's an indirect AI, it still looks for the help of the embryologist. You probably know this paper which was published last year, 2019, in Human Production by Angus Tran. He's actually running a company, Horizon AI, and they developed a deep learning algorithm in Australia together with David Gardner and several clinics from the Virtus Group. And they actually published that in Human Production, and they called it Ivy. Ivy is one of the first, I would say, AIs which is really doing directly everything. Now, I must confess, this is now actually my bias a little bit. Vitrolife has acquired the Ivy technology or the license to use this technology and has developed that into a so-called IDA score. IDA score is like KidsScore, the next step, and IDA score is Complete Intelligent Data Analysis System. That's the name, IDA. Now, when you look on the initial Ivy score, it was actually based on 8,800 embryos from 8 clinics. The when Vitrolife got access to this technology, they actually used the huge database at Vitrolife and they added more embryos. So the IDA score has been now tested and developed on 115,000 embryos from 18 clinics. All these clinics with very, very different settings, very different media in all over the world, from Japan to the United States. And you can see actually that it's quite a large number of transferred embryos with a negative and a positive fetal heart. Now, what has been done here is a huge number of data which were put in. IV initially was only one focal plane. IDA score now is a number of focal planes, or all focal planes which are used. There are a lot of frames which are used for running this algorithm. And the algorithm uses a lot of image analysis in order to increase the quality of the images and the quality of the videos. There is a lot of data sampling done from different clinics. And what we talk about in AI, and I just heard from Keshav that there was a talk from Dean Morbeck some time back regarding AI. So I guess you are a little bit familiar with artificial intelligence and how it works, but it's all about this neural networking. And I can tell you that a good AI really depends on the size of your database. The more data you have, the better it is, the more consistent it is. It depends on the architecture. That means how you design the system, how you set it up. And it depends on the so-called loss error function. That means these are functions which help to streamline the AI in order to make this self-learning in a very, very, very efficient way, and in order to understand things which are really not important or obsolete. So an AI can do a lot of things by self-learning, but sometimes you still need to tell the AI something which is actually something which should be thrown out. So the direct AI method, I think, is actually a perfect solution for IVF, because what you do is you start with a model which predicts on data. When the data are tested, you can test it with the outcome. You can look on the errors. The model itself will detect errors and it will actually adjust itself, and then it will predict on the data. So this is a continuous circle which goes on and on and on. And by that, we have this self-learning continuity, which means finally that the AI is getting smarter and smarter and smarter. It's not only that, it's also that the AI, for example, can at some point be used for certain patient populations. Let's say you have, for example, patients which have only a high body mass index. You can actually try and start develop an AI only for high body mass index, or you can develop it for endometriosis patients, or you can develop it for hyper responders. So it's actually quite a lot of possibilities we get with an AI. The nice thing is, and that has been shown already, there's a publication on the way about that, AI can generalize to any clinic. And that's really fascinating, because it has been developed on so many different data sets that it really accepts every new data set. There is no IVF lab which can be so out of the scope to all of the others that it wouldn't work. It's quite robust in terms of patient age, insemination method, length of incubation, if you culture to day 5 or day 6, doesn't matter, and also the culture media time. So it's a pretty universal algorithm, I would say. And that brings me to my last slide, or pre-last slide. And you can read here that prediction algorithms in clinical embryology are a continuous evolutionary process. But I would say with the recent developments we see now, I call it a revolutionary process. Why? Revolution, because when we have this direct AI methodology, which does an automatic assessment, which is absolutely objective, you don't need the embryologist to do any annotation at all. It doesn't mean that the embryologist is, I would say, not good, but definitely an eye is objective. Embryologists have subjectivity. And there have been several publications. There was recently a publication, again from a laboratory from Dean Morbeck, where they showed that in the different laboratories from Fertility Associates, they actually could see very different ways of how embryologists scored blastocysts and how they used the blastocyst. So in one laboratory, for example, blastocyst was discarded. In another one, it was the best for the transfer. Same blastocyst, quite amazing. This will not happen with an AI, because the AI will be objective. And the important thing is the workflow, because the workflow will change. The embryologist will only place the embryo after insemination into the time-lapse system, come back on day 5 or day 6, press a button, get the score, and know exactly which embryo to transfer and which embryo actually to cryopreserve, and maybe which embryo to discard. So I think we are really moving forward into very exciting times. That is my overview at the end, I would say. We have this continuous automatic AI observation, which will develop further this kind of deep neural networking, and we will get AI-based ranking of embryos by fetal heartbeat, actually, not even implantation, by fetal heartbeat. And this will really give a very good clinical outcome on the other side. So I guess the field will move in this direction, and I'm really looking forward to this development. And I'm also looking forward to your questions.
Thank you, Markus, for a very concise and a very crisp introduction to the session today. I would request the audience to please, if they have any questions, please put it in the chat section. I'm going to start with a few basic ones for you, Markus, at the moment. I think one of the most basic question, if I would say, is where does time-lapse help in a laboratory? Does it really help patients? Because if you look at the meta-analysis, I'm sure you mentioned one at the moment, but Cochrane is something which is followed so much by all of us. And that goes on to say that it's not really improving the live birth. We still don't know whether this technology is useful or not. I am very against such a statement, because I routinely use time-lapse and I see that difference that technology is making. But what do you have in your, what have you seen in your experience that can actually convince people that this is a technology which will really help their patients?
So first of all, you mentioned Cochrane.
Yeah.
And everybody who has free access to Cochrane, I would recommend that you open up the Cochrane report. You scroll to the very end, because at the very end is where people can give critical comments about Cochrane. And then please read the 6 or 7 pages which Chapa and me have written and sent to Cochrane. You must know that Cochrane is using the data as they get them from the authors, when they ask some questions to the authors, and then they put that into a report. And the Cochrane report is, for example, not trying to use the same definitions. For example, in the EV paper, which was published by Markus Montag, that had the first last randomized controlled trial, they actually used as a positive pregnancy the positive beta-HCG. And in the Cochrane report, the numbers for the positive beta-HCG were taken as clinical pregnancy rate. And that, I think, is an obvious mistake, which they did again and again, and it's not yet corrected. The other thing is that, for example, Cochrane relates the miscarriage rate to the number of patients which are intended to treat. That means to all the patients, not to those who got a pregnancy, not to those who got an embryo transfer. So there are obvious mistakes, I would say, in a Cochrane report. That's why I don't like this Cochrane statement. Everybody reads the conclusion of the authors and thinks, okay, time-lapse is not worthwhile. Now, if you look a little bit out in the world, I have a few examples which I think are quite amazing. Probably a lot of you know Cornell University. Cornell University with Seth Rosenberg's a very appreciated center in New York. They have moved to 100% time-lapse already 5 years back. They are doing everything in time-lapse. The example which I think is for me the most convincing is actually Cartolatis Clinic. Probably you know this big unit in Tokyo where they do something like 35,000 cycles every year. It's low stimulation cycles. And Dr. Kato is a very smart guy. He's a businessman as well, but he also looks on the results. He has invested in starting with time-lapse. His laboratory, meanwhile, is 100% time-lapse. And this with a stimulation cycle where you only get 1 or 2 or 3 oocytes, not more. And he more or less has the complete data to show, and I put some of them in this talk, to show that even if you can't select, you get a benefit simply by having undisturbed culture. Even if you can not select among more than 2 embryos, you still get a benefit. And you get this benefit whether you do it on day 2 or on day 5. So I think it's quite convincing data out there. When we go back in the past, I think in the first three years of time-lapse, there was this so-called hype. Then came this drop down where people started using it on a broad scale and not everybody got the right results. But after that, actually, I think we are now in the second rise where people really see the benefit of the results. And I think that has to do with the fact that, first of all, more people know now how to use it. For example, one of the big issues is how you make the slides, how you try to avoid evaporation. And I think it's a handling issue in some countries, especially if you want to save oil or you want to save money or you are not really doing a precise, good job in the lab. And time-lapse will not make your results better. But I think if you are having a decent, good lab and you use time-lapse, most people will see a kind of improvement.
Yeah. Yeah, so you mentioned, I'm just going to follow up with another question because you put it out there that obviously Dr. Kato is doing low stimulation, and in these scenarios, we have very few eggs, we have very few embryos, and where you're mentioning that here the selection might not really play a role, and it's probably because of uninterrupted culture. So do you feel, because a lot of people also feel this, that most of the advantages of time lapse is because of uninterrupted culture? Do you feel that the algorithms that are being put in and all the different scores that are available really aid, or it's just the uninterrupted culture which is improving the outcomes?
No, I think it's a combination of both. So uninterrupted culture has been shown to be really a kind of benefit. And but I like to say that this is maybe not true for every laboratory. I'm pretty sure if you are running a laboratory where you have one incubator per patient, you will not see any big differences in terms of undisturbed culture because you're already running on a very low opening of your incubators. But many people don't have that. And especially, for example, in China, there are laboratories where they put 20 dishes in a big box incubator, which is a nightmare. So undisturbed culture definitely helps if you have to open your incubators very often. I think the other thing is that when we come to the algorithms, as I mentioned in the last slide, the algorithms are giving a new perspective, and that is objectivity. The algorithms are giving quite consistent grading of your embryos. They are not discussing, and we all know that I say this is a 4AA and somebody says, oh no, that's a 4AB or 4BA. And I do that on my workshops, you know, that I show blastocysts to embryologists and I let them grade. And then I write it down on the table and show it to everybody. And it's quite amazing because sometimes you get everything from 3AA to 3CC for the same blastocysts. So the algorithms will definitely aid because they will make it absolutely objective. But I think the other advantage of the algorithms is they will take away the annotation from the embryologist. Now, even if you, for example, make KIT score day 5 manual, you will need for every embryo at least 1 to 2 minutes to do the annotation. The AI does it quite fast in a few seconds, and it does it almost in the same way. For example, if you make KIT score day 5 today on one embryo and you take the same embryo 10 days later, you will not get the same values. I'm pretty sure. Even I will not get the same values. So the AI will give you the same values and the same score again. And I think that is one of the things because embryologists will have time to do other things. And other things, I mean, mostly quality control or being less stressed and hectic in the laboratory.
Yeah. And like you just mentioned this again, and I'm going to put it back in. Like I have a laboratory and I have 4 embryologists with me. And I see this quite often, whether when I'm annotating, the score is a little different. When the other embryologist is annotating, the score is a little different. And so how precise do you actually have to be with your annotations? Or is there like a small range that you can follow? Or should I be worried about such a scenario?
I think it depends a little bit on the algorithm you are using.
Yeah.
Because Vitrolife is not the only company putting out algorithms there, of course. But I can tell you that the algorithms which were developed try to use so-called relative timings. The worst thing you can do is, for example, use a variable where you say T5 must be faster than 48 hours.
Yeah.
That's always the worst thing, because it can be that in one patient, all your embryos are in the bad scenario, or it can be that with a different culture media, it will not work. That's why in vitro life, it was actually, there was the relative difference of cell cycle lengths. And that is independent of the culture media, that is independent of the age, because you have a shift across everything when you have an older patient or a younger patient. So in there, it will only change with morphology. Yeah. So the timings may not be such a big issue, but I guess the morphology is when really getting an issue, because then it's, the morphology will decide whether your embryo really gets into the high scores or into the lower scores. Yeah. And especially the morphology is something which is sometimes very subjective, where I can see a lot of variation between embryologists.
Okay, so let's go to a few questions from the audience. I think the first one that I would want to put out here, because it pertains to what we're talking about here, is about undisturbed culture or uninterrupted culture. So Dr. Firoza here is asking, does uninterrupted culture mean that we don't change the media on day 3?
That's a good question, because in the beginning, when TimeLapse came out, most people were still at the sequential media business. Now, we all know that in the last 5 to 7 years, the single-step media have taken up tremendously. But with single-step media, I like to be very precise. I mean media which are really developed to be used from day 0 or day 1 up to day 5. There are some media where media companies have developed a medium which was a single-step medium for changing on day 3. So try to find that out with your single-step media where it has to be changed or not. Yeah. Now, when we talk about the continuous culture media, which are used from day 0 to day 6 or 5, actually, when people started using that, they realized how many time they save in time-lapse by not changing on day 3.
True.
I can tell you that if you look on the results between sequential media and single-step media in time-lapse, I think you will not see a big difference. There is actually not many studies out. There is one study which compared G1, G2 with GTL, where GTL was slightly better, I would say, in terms of the outcome, but it was not significant. So when you really have a good sequential program, stick to it and just change on day 3. But do it in a proper way. And of course, you need to take out the dish, and you will disturb a little bit the dish when it's out, but you will not disturb all the embryos which are in the culture, because the systems are built in a way nowadays that the conditions, even if you take out the slide, are not affected inside the time-lapse device.
So this means that obviously sequential medias can also be used with the time-lapse systems that are available. But so how do we basically change the media? Like, because I know that there is a smaller well and then there's the well above it. So you just take out the media from the above well and then put the other media in. Is that?
That is correct. I mean, every company has probably, depending on the dish, different strategies on how to do that. Okay. And obviously the one which you just explained, by taking out from the outer well and then putting into the outer well, you will have then after that a very slow mixing. It will take some time until in the smaller well, the medium is really changed. Yeah. If you really want to change definitely 100%, you need to go into a new dish, independent of which culture medium and which company of a device you are using.
Yeah,
that I think is also one of the reasons why people like the single-step media, because it's more or less, I would say, you know the media and where it is in for the whole time.
And it's easier to use, and we know by all the literature that's being published that there are no significant effects of continuous culture for day 5 or even till day 6 on the embryo, especially because of the kind of chelators that are being present. The ammonia is going to go, etc., etc. So like I've always used it with single step media, and like I've been very happy with my results. So, but I've never really tried it with sequential. I might just do that and try and see the difference.
Yeah.
Okay. Yeah, we have another question which says here that can time-lapse help the laboratory in doing day 3 transfers?
I think yes. Because KidScore Day 3 is quite an obvious algorithm which was tested and developed, especially for Day 3. I guess that also the automatic AIs will sooner or later be developed for Day 3, maybe even for Day 2. Who knows? Because I guess that the AI is so smart, taking up things which we can't see, but it probably can detect among embryos already until Day 3 certain features which are good. Still, I'm very much convinced that if you run a Day 3 AI and a Day 5 AI, the Day 5 AI most probably will do better because you already have a better selection possibility on Day 5. Yeah. But still, I mean, Day 3 has its benefit and Day 3 has its advantages. And especially if you are afraid about long culture or, for example, some labs, when they have only one time-lapse system and they have many patients, of course, running Day 3 allows you to put in more patients.
And it's a good tactic in the sense that if you want to reduce the number of embryos to be transferred, if you want to reduce the multiples which can be associated with multiple embryo transfers at Day 3, then selecting an embryo at Day 3 with the best kid score can actually help you in doing that.
Yeah, I can give you one example, which I think quite interesting. You all know China, and China is still in the majority of centers a Day 3 transfer society.
Yeah.
They mostly transfer 2 embryos on Day 3, simply by morphology. And they actually do have patients where the mean age is around 31, 32 years. The multiple rate in China is 60%, which I think is incredible. I don't know about India, but in Germany, this would be absolutely unacceptable for the health system. It's the neonatologists who are really screaming and shouting at the IVF people because they produce so many multiples. And the neonatologist guys have to deal with the problems later on. So I think whenever you are doing something with Day 3, you should have the best algorithms or the best selection possibilities also to do a single embryo transfer. And I guess that is where we are moving to, where we should move to.
Yeah, I think that's where conventional morphology fails a bit, because at Day 3, even like you touched upon it very briefly about like the different cleavage patterns that can exist, but at day 3 we are only assessing just a snapshot of the embryo, and it's not the whole development till Day 3. And I think that's where morphogenetics really plays a role. If you want to do single Day 3 transfers and improve or optimize your results, I think it's a very, very good tool to have in your laboratories.
Yep, definitely.
Yeah. Okay, so let's move on to the next question. This is again pertaining to poor responding cases. Dr. Bezar has a question like, does TimeLapse have favorable results for poor responders for extending the culture to Day 5 or post-biopsy embryos as well? So your experience here?
Of course, I have no personal experience, but again, I like to give you the example from Carter Ladies Clinic. It's quite fascinating.
Yeah.
In Carter Ladies Clinic, they have a building with 12 floors. They have 2 IVF laboratories, one on floor 7 and one on floor 8. Patients coming for this first cycle go to floor 8 laboratory and they get a transfer on Day 2. Patients coming for a repeated cycle, they go to the floor 7 laboratory, and now they have usually 2.2 embryos in the mean, which is like a poor responder, and they culture to Day 5.
Yeah.
And they have amazing blastocyst rates, but I think this is probably more due to the low stimulation cycle. And after introducing TimeLapse, they actually could see an increase in their blastulation rates. Before TimeLapse, they were using Aztec benchtop incubators, you know, with small drawers, which I consider is already a pretty good incubator because it has very low volume, it has very good recovery times. But moving to TimeLapse and undisturbed culture, they could still rise the blastocyst rate on Day 5 with low stimulation cycles, which is a little bit like poor responders having only very, very few embryos. So I think definitely it's a very good argument, I would say, also for poor responders. So you try to give the embryo the best possibility you can get. What about biopsies? I mean, if you talk about post-biopsy incubation, you probably do the biopsy on day 3.
Yeah.
I personally know that many centers, of course, try to go away from day 3 out of obvious reasons. But if you still do it, I would say there is nothing which is against culturing after day 3 still in time-lapse.
Yeah, we're going to come to the section where we discuss aneuploidy and time-lapse and the correlation that happens there. So I'll touch upon the few questions which are there regarding this topic at that point of time. Let's go to the basic questions first, and we're going to talk a little bit about the safety of the technology. Now, we know that we're taking pictures of the embryos and there is some light exposure, which it's a myth that people feel that the light exposure is too much. So the next question, I don't know who's asked this question, but are there any proved disadvantages or safety checks regarding the relentless light exposure during the capture of embryos or during when you're capturing the pictures?
Well, it's a very nice question because it comes every time. There are, I think, 2 or 3 publications already out there. One publication is a very interesting one because it's a publication that really calculated the intensity of light which you get during exposure in time-lapse and in your normal standard laboratory practice. Now in time-lapse, you must know that we are working with a wavelength which is 630 nanometer. So it's a little bit lower energy light than we have in our normal microscopes or in our normal stereo microscopes. And even if you illuminate an embryo over 5 or 6 days for every 5 minutes on 10 focal planes, your total light exposure is less than what you do in your daily life today, where you take the embryo and you have it on the dish for IVF, you have it for ICSI, you have it for PN check, you have it for, let's say, no day 2, let's say day 3 and day 5. Even if you only do that, you are exposing it to more light than in a time-lapse device.
Yeah.
So I think these publications are out. If you want to know them, just scroll around in the VitroLife homepage. I think there is somewhere in the frequently answered section, there is something where you can find this publication.
And I think most of the meta-analysis, etc., have ruled out the possibility of any safety issues with time-lapse. I think we have enough data to support that this technology is safe to use for patients. Okay, let's move on to the next question, and that's basically about the different kinds of time-lapse incubators that are available. And so a few people have asked me, Dr. Firoza has asked me this question. There's another anonymous user who's asked this question. What would you look for in selection of a time-lapse incubator if you're thinking of buying one?
I think that's a very difficult question because you know that there are different systems out there in the market. I think it has to do a little bit with how is the service in your region. Can you get access to a service technician? Of course, at the moment, this is a little bit restricted due to the worldwide situation, of course. But if you buy a time-lapse machine from a company who is not able to send a service technician within 1 day to you, then I think it's a really bad decision. Yeah. The other thing is you should look a little bit on the size of the dishes, for example, because you can save a lot of money by having very smart dishes where you use only very little oil and very little media, and there are differences between companies. I would also look a little bit on how is the development. I mean, is this a company which is actively developing further the technology in the field or not? Or is it a company which simply has only one device and that's it, and it's not selling much devices? Because then you also know that maybe the development of both software and hardware is, not as good as it could be.
Yeah. So a lot of things, and I think the point that you mentioned about like companies being actively involved in like updating the softwares, updating the technology, etc. I think that for me is one of the key selling points, and like I would want to choose a company which has those features, and then maybe look for it, because I want the technology to evolve as time progresses, and with so many like new things which are coming up, especially with AI, that's something that I really look forward to in the future.
Yeah.
We're going to move to a few questions regarding the algorithms. Now, there's a question here which basically says, how do you correlate algorithms in embryos which are produced from ICSI of matured oocytes, or from ICSI from, like, let's say IVM, or if it's from an immature cohort? Is there any data related to this?
I just saw some data recently where people actually looked on immature oocytes. I think these data will come in the very near future, mostly from China and from Japan. Because in China and Japan, they are dealing very often also with immature oocytes and still culturing them further on. And I think at the moment, what we have is quite low numbers on the data which are out there. And I think we need larger numbers. So what you need to keep in mind is if you incubate immature oocytes, which have been, let's say, injected half a day later than the mature ones, and you have them in the same dish, then of course your algorithm will not exactly work on it because you need to adapt it. Yeah. And I think that is one of the problems at the moment.
Yeah. All right. But do you think that time-lapse could help as far as IVM is concerned? Would we be able to get a better selection for in vitro matured oocytes? Or
now we are talking about real IVM, and if we talk about real IVM, then the situation is different, because there is a publication, or there are two publications out where they compared the timing of real IVM oocytes and normal oocytes. Real IVM, I do mean that you do the pickup at a very, very early stage, that you have to mature them over 1 to 2 days in your laboratory before you do the ICSI. So not that you have a metaphase 1 or a GV oocyte from a stimulated cycle, right? And if you do that, then you can see in these two publications that there is a benefit by using time-lapse for these oocytes as well.
Because like I was just going through a few Twitter posts yesterday where there's a huge meta-analysis which has come from, I think it's come from Vietnam, and they have compared IVM with IVF, and they found the newer protocols to be quite beneficial for patients. So we might see a change in the stimulation protocols which happen for our patients, where a more safer protocol would be utilized. And we're hoping now that the time-lapse system can also be integrated into this. Do you feel that the ICSI time might change when we use time-lapse, when we're doing IVM?
I'm not sure, because I think what you should really consider is that your standard IVM will still take place in a normal incubator.
Yeah.
So that means because you still have at that time the cumulus cells around. And I think it will be not possible to do the IVM in a time-lapse because you can't see the development. It's too many cumulus cells around, so you really can't see it. That means your timeline starts more or less at the point when you really stop it. And when you start to do the ICSI over IVF. And that's why I think these times may not change very much. No?
All right. Let's talk about aneuploidy and the algorithms and the different features that are associated with aneuploidy, because I think I read, I can't really remember the name, but there's a clinic in UK which published data on algorithms, especially multinucleation at day 1 and day 2, a 2-cell and 4-cell, and their correlation with aneuploidy, and also the different cleavage patterns and their correlation with aneuploidy. And they're saying that there might be a time in the near future where we might be able to predict aneuploid embryos just by looking the morphokinetic parameters. Do you believe in that?
I think that when we look on the manual assessed morphokinetic parameters, I think this will fail. Okay. Because we already now know today that there is a correlation, but this correlation goes away if you look into different age groups, or if you looked on different culture media. It's quite interesting. So that means you can't generalize that. It would mean that every clinic would need to have her own morphokinetic evaluation regarding to aneuploidy results. And I think that is a nightmare. That's not possible. But I guess as soon as we come to the really direct AIs, I would say that at some point they might be able to give you a kind of judgment judgment like, okay, this embryo might have an aneuploidy 90%, this one 30%, this one 50%. It will never be 100%, but it will give you a guidance. And then you can decide, is this an embryo I'm going to biopsy or not?
Okay. So it might help us in reducing the number of embryos for biopsy, ultimately reducing the cost of the cycle and like.
Yeah. Or what I sometimes say, you still do the biopsy of all the embryos, but you don't do the diagnosis of all the embryos. You only diagnose those which are more, I would say, easier. But I think, again, this will change as soon as we get non-invasive PGT, because you then have the culture media sample, and I guess that might be much easier. So you have a kind of PGT score from an algorithm. And if you're in doubt, you test the culture media. Well.
Okay. Again, since you're talking about algorithms, like which algorithm do you feel is the most robust? I've only used the kids score day 3 and day 5, and I've not really forayed into inputting the other algorithms into the embryoscope. But do you think that there are some good algorithms out there?
I can tell you that probably the direct algorithms like IDA-score will outperform
Everything.
Probably everything.
Yeah.
But to give it a little bit more on a general and universal answer, if you use an algorithm, you should use an algorithm which has been developed on large data sets from several clinics with different conditions. Because one of the pretty good algorithms, I would say, in the very beginning was the one published by Markus Montag. But this algorithm was developed on high oxygen. If you haven't read the paper and you used this algorithm in your clinic with low oxygen, you failed. So you really need to know where the algorithm comes from. Is it a multi-clinic algorithm or is it an individual clinic algorithm? And that makes already a big difference. There are certainly now AI which are published based on 20 embryos. Don't ask me, because with 20 embryos, you can make an AI, but it will not work in every clinic.
That's true. Again, this is regarding aneuploidy. What are the different markers that you feel would be important as far as the morphokinetic parameters are concerned? So what would a clinician would want to look at just to try and assess the kind of percentage of aneuploidy that you were talking about earlier?
So if you talk about morphokinetics, I think what we can tell is, first of all, direct cleavage is usually always correlated with a high aneuploidy rate, whether it's direct cleavage 1 to 3 or 2 to 5. And that you can see in the morphokinetic variables quite obviously. Then I guess there are some algorithms where we looked on the time from morula to blastocyst formation, which seems to be also a little bit better in terms of correlation. But I think what is really interesting is there is one paper by Lagalla from Italy, and the one paper which I just showed about multinucleation. These are papers where we are looking on the exclusion of blastomeres at the molar stage. Yeah. And I think this is something which is getting more attraction or attention nowadays. And I guess that is where we will get more data and input in the near future, how to use that, because this seems to be really a kind of correction mechanism of the embryos.
Yeah, so I also did, so I presented a similar thing at Aspire a few years ago, where we took these embryos which were excluding blastomeres at the morular stage, and we also did a biopsy for these embryos. And like most of the embryos actually came out to be normal. So like you're telling that this could be a self-correcting mechanism, we also felt the same, and that's the kind of data that we also presented. Obviously, it was a very small study, but like I completely agree with what you're saying at the moment.
Yeah.
Okay. Do we have anything to actually predict the outcomes for day 6 blastocysts?
I'm seeing sometimes a little bit more data which are not yet published. So I would say that
leak a little bit information for us.
For day 6, I would say that the algorithms work equally well. Okay. Because even if you get a blastocyst which did develop slowly to day 5, you will still get a score on day 6. And on day 6, you can still go by the score. And what I think is really amazing is that we are now understanding and learning that day 6 can give quite substantial amount of live birth. If you screen a little bit of literature, you will find recently in the last 2 or 3 years, something like 3 to 4 papers where we really give a lot of details about live birth of day 6 embryos, even low quality. And I think this shows that morphology is no longer the main indicator when we come to these late stages. It's really about how the embryo developed. And even if it was a slow development, if a development is in a certain pace, it seems to be quite okay in regard to implantation. Not as good as say 5, of course, but.
So I recently had a case, and I shared the video of that those embryos in one of our WhatsApp groups, where the embryo was actually compacted at day 3, and then there was like a reverse compaction which occurred. So it became an 8 cell again, and then it became a morula at day 4 again, and then obviously it became a very good blastocyst. And it was kind of like, so when we were annotating that embryo, obviously when it compacts, you put it as like, you mark it as compacted or you mark it as C, and then then what do you do after that? Because if it's going like, if it's showing reverse compaction, I can't just go back and like change the annotations. And it actually got a very good score from the kids score system.
Yeah. So normally what is it's a little bit difficult, right? But what you normally do is you grade it, or you do the annotation when you see an event to happen for the first time.
Yeah.
And let's say when we talk about reverse cleavage, where we have 4 to 5 to 4, you annotate 4, you annotate 5, and when it goes back to 4. But what you will get then is a very late T8.
Yeah.
And that is where the score then goes down. So it's not reflected directly sometimes in the scores or in the variables which are really changing, but it's then reflected in the variables which are later in the annotation timeline. And that will actually downgrade sometimes the embryos.
Yeah, because like it actually it was one of the best embryos for transfer based on the kids score system as well. But I was still skeptical because I was seeing this for the first time, so we didn't transfer it. And like a lot of people suggested me to biopsy that embryo, but then we didn't have the cells for biopsy at that moment. So that was an interesting thing that I saw. Like this was this month itself. Okay, so last few questions for you, Markus. This is from Vikas. Thank you for an informative talk and like a wonderful session. With the advent of parallel developments of various AI like IDA-Score, Erica, and all the others which are coming up, do we need to find a way to standardize the AI scoring systems as well?
Yeah, that's a very good question. I really like that because there are discussions now starting where people say, okay, what do you report for an AI? Because some people report the area under the curve. Some people also give probability scores. And I think what we really need is we need to have a certain kind of standard, and that is what is proposed. There is a paper which has been submitted. It's not yet accepted, but this paper takes exactly this discussion up and says, yeah, we need to really find, in order to compare the different algorithms, every algorithm should state certain baseline parameters, like, for example, how many clinics, how many embryos, how many transferred, how many not used, and what is the area under the curve for the transferred embryos, what is the area under the curve for all the embryos, what are the probability scores, and so on. So I guess that's something which is at the moment still not there, but it's definitely needed because that's the only way how you can potentially compare algorithms. Another way would be that there is something like a kind of open embryo library where every algorithm can have access to and then be tested and be compared to each other. Yeah. But I guess that because this is also a commercial world, that might be quite difficult to get realized.
Quite impossible. I wouldn't say difficult. It would be probably impossible. Like obviously the economics is taking over healthcare, and I think that's something that we all have to be worried about a bit. We have a question on autocorrection, and this is Dr. Yuvraj. If you believe in the concept of autocorrection, even at the nascent stage, then do you think that the whole basis and relevance of time lapse is lost because the embryo is self-correcting? Why do we need those morphokinetic parameters later on?
That's a good one, because if you don't have time lapse, sometimes you don't see that the self-correction is happening.
Yeah, that's
so it's quite interesting, because if you look on a blastocyst grade 4, which is expanded, very often you can't see whether this embryo had somewhere anything extruded or not. So self-correction always goes with a kind of event which is probably visible. If you don't see that, if you miss it, then you will not know. And you might maybe take another embryo. That's exactly the point. And also, if you look on those embryos which have undergone self-correction, because they extruded something, in my experience, embryologists grade the trophectoderm of these
really
embryos
bad.
usually bad.
Yeah.
And in reality, they are quite good, right?
That's
so
true.
you would definitely miss them if you follow your normal standard morphological scoring. That's exactly the reason why time-lapse is the perfect tool, especially for these embryos.
Yeah. Because the blastocysts will grow, and the blastomeres which are extruded, it generally crushes those blastomeres, and it actually appears like a C-grade trophectoderm.
Exactly.
And most of the embryologists would really not choose to transfer such embryos.
Yeah.
And so I was reading a very recent paper which actually mentioned that if you're seeing signs of blastomere extrusion, you do hatching at day 4, so that extra material can be like extruded from the blastocyst itself, and you'll have a better grading. So maybe that's something that could be utilized by such embryologists.
Definitely. And also sometimes if you see when blastocyst collapsing, then you also see this in the parietal space. So I think it could potentially help to do assisted hatching. Yeah, that's right.
Yeah. So last few questions for you. I think now let's move on to how to use the technology. So do you think that there is a huge learning curve to actually understand and utilize a time-lapse incubator?
I think it depends a little bit on the system, of course, but to my experience, the biggest learning curve and the most important is how to make the dishes in a proper way. Because if you now think you prepare a dish which will be in the incubator for 5 or 6 days, if you don't do this dish right, you will have a problem right from the beginning. For example, if you don't take care for osmolality, for pH, when you have bad conditions which you maintain for 6 days, and that will definitely damage the embryo. And when you do things worse, when if you change the dish every second day, like maybe in your standard incubation model. So I think that is the biggest learning curve. If it comes to morphokinetics and annotation, I guess the direct AIs will be soon overtaking everything.
Yeah.
And then I think it doesn't matter how you do the annotation, whether you do it good or bad, the AI will tell you, and it will be better than you, will be even better than me or anybody else, or even you, Keshav.
No, 100%. I agree in that statement, because like AI is so fascinating, and we've had so many speakers who've talked about AI, and I think it's something that I think all embryologists would look forward to. But like you mentioned, I think the only learning curve that's associated with time lapse would be to actually prepare the dish in the correct fashion. And once you master that, and once you master the loading of the dish, I think the rest of the things are quite easy and doesn't really require much like expertise. We have a interesting question here by Dr. Saili, and she's asking about some other parameters which could be incorporated into the scoring system now. So she's asking, how do we annotate hash blastocysts or laser hash blastocysts, and do algorithms consider hatching in their scoring?
Oh, that's a good question. And I really must say that I don't know a perfect answer for that. I can tell you that if you do a manual annotation, There are certain tricks how you can still find the right TB if you did your hatching or laser treatment on day 3 or day 4. You simply need to look and watch out at what point is the embryo moving into this opening. And that is exactly the point where you have TB. I think for the direct algorithm, it depends on how many numbers of these embryos we will see. As soon as the direct algorithm has seen maybe a couple of hundred of such embryos and knows the outcome, it will take it into account and then more or less be able to consider this.
I think I'll only put one point in this specific discussion, and that's like we've already seen a lot of meta-analysis on assisted hatching, and like I started with Cochrane for assisted hatching as well. Cochrane says that there's absolutely no benefit of assisted hatching whatsoever. So do you think that it would really make a difference whether we're incorporating that point into the algorithm, if you look at the data?
Yeah, I wouldn't include it. And for example, even for biopsy, maybe you know that a lot of people who do nowadays day 5 or day 6 biopsy, they no longer do a laser treatment on day 3 or day 4. They do it directly before they do a biopsy. So I guess that this will slowly go away and it will be maybe not that important any longer. And so that's also why it might be not included in an algorithm.
Yeah, and I think you've answered the next question by Saili, because she's mentioning that they tend to do biopsy on day 4 for the hatching. So I think you've just covered that question as well.
Yeah.
So last question for you, and I'm sure a lot of people from the audience can also pitch in their comments here. Would you like to use time-lapse for all your patients?
So I can tell you that the biggest trouble in the lab is when half of the patients get time-lapse and the other half not. Because when you are running actually 2 systems side by side, it depends whether patients have to pay or not, because then it also depends on who is going into the time-lapse and who not. So I think if I have a choice in a perfect world, I would use 100% time-lapse for everybody and don't discuss about it. That's it. Makes my life easier and also the discussion with the patients much easier.
Yeah. And when we're talking about the commercial aspect, I'm not sure what the situation is in Germany. Do people charge extra for time lapse?
That depends on the situation of the centers, but usually they have to pay a little bit extra for time lapse. But when it also depends on other situations. For example, in the past, some centers have charged money for sequential media, you know.
Yeah.
Now, if you start using time-lapse, definitely you are no longer charged for sequential media. You just pay for time-lapse. So I think it's a world where everybody needs to find out how to finance that and how to use it in their own practice. And some may charge and some may not charge.
Yeah. Awesome. So thank you so much, Markus, for sparing so much time with us today and actually creating such a nice deliberation that happened today. And thank you to the audience for asking so many questions. Really enjoyed moderating this session, really enjoyed learning new things about time-lapse. And again, very, very thankful to all of you for attending. Before we end, I'm just going to share my slides a bit because we have a few things that we're launching now. And I would really request all of you to go to our website because all the information about the courses, etc., are mentioned on the website. It's www.metaembryology.com. And we are doing our next course in October, and that's going to be on reproductive genomics. That's from the 23rd to 25th of October. And we have amazing faculty. I'm very, very grateful that Dr. Firoza Parekh is going to be one of our lead faculties for this course. And we are really looking forward to that session. We have also opened up our hands-on courses. Obviously, you all know that COVID is still amongst us, and we're still trying to be as safe as possible. So our hands-on courses are only restricted to 1 participant at the moment, and these are also open. So you can actually check out the courses on the website. And lastly, we are starting a subscription for our courses as well. And lots of benefits for the subscription. Like you can see, we have a lot of speakers who've actually spoken at this platform, and now Markus is also going to be one of them. And we really look forward to you subscribing to the kind of benefits that we have for all of you, and really hoping that you all can benefit from the kind of information that's shared on this platform. So thank you so much for attending today's session. Thank you, Markus, and hope you stay safe. Hope you have a good time, and looking forward to seeing you very, very soon.
Yep. Stay safe, Mara, and everybody, and see you again in India one day.
Yeah,
Bye-bye.
looking forward to it. Bye-bye.
Bye-bye.